Hi, I'm Dr. Connie Amundsen. As a chiropractor, I've been concerned with the health of my patients and with the health of Americans for over 30 years. And in that time, I've seen a decline in the overall health and have discovered that we in the United States rank far below other Western nations. Now, as a graduate student at the University of Washington's Department of Scandinavian Studies, I'm focusing on what we can learn from other Nordic countries, from the Nordic countries, because they are seen by other European countries as leaders in health and health policies. So I'm going to just scroll through this and ask a few questions and bring up a few things that will enlighten us about the necessity for taking a look at these issues in the United States. In the U.S., we spend 2.5 times more on health care than most developed nations in the world. Does that mean we're 2.5 times healthier? No, not really. A 2009 report from the Centers for Disease Control called The Power of Prevention makes it clear that this is not the case with these compelling points. First of all, 75% of U.S. healthcare is spent on chronic lifestyle diseases, causing 7 out of 10 deaths. The U.S. spends significantly more on healthcare than any other nation, currently more than $10,000 per person per year, yet our average lifespan is far below other nations that spend half or less on healthcare. And in 2005, 133 million Americans, that's almost 1 out of every 2 adults, had at least one chronic illness. The report goes on to state that although chronic diseases are among the most common and costly of all health problems, they are also the most preventable. Chronic disease prevention, to be most effective, must occur in multiple sectors and across individuals' entire lifespans. Prevention encompasses health promotion activities that encourage healthy living and limit the onset of chronic diseases. It's even worse if you're poor. According to a study recently published in the Journal of the American Medical Association, life expectancy in the U.S. varies by more than 20 years, depending on which county you live in. One of the authors, Dr. Christopher J.L. Murray, who's here at the University of Washington, states that a combination of poverty, that is socioeconomic factors, such as poverty, income, education, unemployment, and race, were independently related to 60% of the inequality. So, is it worth it? Given that we spend 2.5 times more on healthcare, perhaps we should take a look at how we compare in terms of common health indicators with 4 of the Nordic countries, specifically Denmark, Finland, Sweden, and Norway. Now, looking again at the percent of gross domestic product spent on healthcare, in the U.S., it's a whopping 17.1%. The Nordic countries are down around roughly 10%. The United Nations every year comes up with a Human Development Index, which looks at 3 dimensions and basically judges countries on how well they're doing. And the 3 factors are health, education, and standard of living. As you can see, the U.S. is 10th, not so bad. Denmark's 5th, Finland 23rd, Sweden 14th, and Norway is number 1, where they have been for many years running. Also, we can look at life expectancy and so forth. But the point is that we lag far behind the other nations in terms of where we stand. Now, I want to make a really clear point that healthcare does not equal good health. There are actually 7 other factors that top this. Number 1, sanitary drinking water, pasteurized milk, safe sewage disposal, work safety. We take these things for granted, but listen to this. Higher standards of living, better education, and cures for many communicable diseases. From this list, we can see how 2 of the dimensions on the United Nations Human Development Index, mean level of education and standard of living, while not directly measuring health, as the life expectancy dimension does, also contribute to the health of the population. In light of this, over the past couple of decades, the Nordic governments have made a shift regarding health policies by institutionally separating health care from health promotion departments. And all 4 countries, Denmark, Sweden, Finland, and Norway, are considered leaders among other Western nations, even though there are significant differences among them in how they approach the issue of fostering better health among their populations. For on the one hand, we have downstream strategies. And on the other end of the continuum, we have upstream strategies. And just to make a little bit of explanation what that means, downstream policies basically emphasize the importance of personal responsibility and personal choice. And upstream strategies focus on structural or socioeconomic factors that contribute to health or lack of health. So there are these policy differences that we see among the 4 countries under consideration. And I have quite a few points here, but I'm just going to make the key, sort of summarize the key elements of each country. Denmark really emphasizes that people should make their own choices, but make the right ones. Sweden focuses on individual integrity and social embeddedness. And Finland focuses on autonomy and social conditions. Norway, as we saw, was on the other end of the spectrum, really focuses on behaviors and living conditions as socially determined, as we've seen in the United States as well. And this is really true all across the world. So there was a study done among 30 European countries and following their public health nutrition policies. And most policymakers perceived that regulatory measures were more cost-effective than voluntary measures, and also that downstream interventions basically don't work. And so there's a wide consensus that upstream policies are more effective than downstream policies. Now, I want to look at some points here in the Norwegian model, but first I'd like to point out that Professor Christine Ingebretsen of the Department of Scandinavian Studies here at the UW has written extensively on the ways in which the Nordic countries serve as norm entrepreneurs or norm exporters on the world stage. But as far as I know, this idea has not yet been extended to health policy. As Norway serves as one model for both a high level of health and a firm commitment to improving its citizens' health, I would like to take a closer look at some key points that distinguish the Norwegian model and then ask what of this model would travel well to the United States, which was, as we have seen, needs some help. Okay, so Norway was the first country in the world to systematically undertake work on priority setting regarding health policy. In Norway, there's also relatively strong general standing of the humanities and social science research. And the principal basis for setting their priorities became the medical and social effects of different health interventions. The second point in the Norwegian model is that they very early on had a recognition that social conditions cause health disparities. And number 3, this led to an official shift in 2003 from downstream policies to upstream policies. They concluded in a white paper that was done in 2007 that equity is good public health policy. This makes sense from what we've seen. And they really were focusing on the challenge of the future being bringing the rest of the population up to the same level as the people with the best health. They call this leveling up. So this leads to a preference for general welfare schemes as they are less stigmatizing to vulnerable groups. From these basic policies and basic facts, they came up with 3 overarching strategies. One was to reduce social inequalities that contribute to inequalities in health. For example, ensuring safe childhood conditions, fair income distribution, equal opportunities in education and work, and so forth. They wanted to reduce social inequalities in health behavior and use of the health services, and also target initiatives to promote social inclusion. Now, thinking about what from Norway might travel well to the U.S., let's remember, first of all, that we have great room for improvement despite our economic and intellectual power. Remembering that the U.S. lags behind other Western nations in many indicators of health, that there is a great disparity in life expectancy between the poorest and richest counties, that health does not come from health care, that policy experts consider focusing on individual choices of failure, and upstream structural changes are likely the most effective way of improving citizens' health. This follows on a vast body of research that we have available to us. So I feel that we in the United States are at a crossroads. We can't assume that our government is going to come up with some rational health policy, certainly not on the national level. We get things on a piecemeal basis from the Department of Human and Health Services, but we are, for the most part, left to our own devices, even though we know that if you happen to be in a lower socioeconomic position, this does not work. So I really would like us to consider two things. One is to formulate a rational health policy and then ask, how can we enact a coordinated upstream approach that levels up those in the lower socioeconomic positions? The Norwegian model began with goal setting and then worked via its welfare apparatus to implement the strategic goals. I hope that we here in the United States, perhaps on a state-by-state basis, could ask these same questions and come up with some upstream solutions that work within the framework of our more disjointed system. If you have any questions or comments or would like to join the conversation, please email me at the email that you see on your screen. Thank you.